locum and things like that. So that's kind of a little bit of background about me. So yeah, we'll be talking about requested investigations today, which is, one of the core things that you need to do as a junior in medicine. So I'm sure this image you're thinking, why, what does this have to do with anything? Um, so actually this was during my time when I was working in London. Um, where we had our cows. So cows are basically computers on wheels. That's what they're short for. So it was the consult. We were on our ward round. We had the consultant. We had the registrar, and then we had all the juniors. So one person had one cow, and the other person had another cow. And the first cow showed, the investigations such as like the lab tests, and the other one had like the X-rays and all the other radiological investigations. So you can see from here, the scrub nurse is handing over the consultant some investigate some instruments. So and those instruments are obviously used to perform whatever procedure he needs. But so in the same way, you're handing over different investigations to your consultant to try and make a diagnosis or to try and kind of do something with it in order to better the patient. So, one of the things I talked about when they told me to say 5 things I would say about, starting medicine in in the UK as a junior, as a F1 or F2, you're not the consultant. The consultant is there to make most of the decisions. What you are to do is, show them, give them the tools in which they need to make those decisions. So you want to be as good of a scrub nurse essentially as possible, and using the investigations that you request. And if you see the really, really good scrub nurses, even before the consultant asks for the instrument, they know what he needs, and they're able to pass it to him. So in the same way, as you gain more experience, you'll be able to give the consultant whichever investigation even before he thinks about it. So that's hopefully what the aim of the talk will be today. So the first thing I wanted to, so the topics will be divided in two. So we're going to talk about lab requests. So in terms of lab requests, we mean things like, your any kind of investigation you send to the lab, swabs, urine samples, blood tests. But in general, we're talking mainly about the blood tests, and then we'll be talking about the imaging. So any kind of radiological requests. I know there's obviously more types of requests that you can do, but those are in general what make up the most parts of your investigations. So, like I mentioned, what the lab requests are. So I was actually thinking, when I started this, and by the way, guys, if you could, I would like this to be interactive as well, so that it's not just me yapping the whole way through. So if you, sometimes I'll ask you to put some things in the chat, or if you want to kind of unmute your mic to, answer a question or something, that would be great as well. So I was thinking, yeah, so why do we request lab tests in a hospital setting? Because most of you will be working in a hospital setting when you first start. So I came up with a few different things. So obviously the most important one is, to help you to make a clinical diagnosis. So you've done your workup for a patient, you've examined them, you have an idea of what you think they have. If, for example, if it's a pneumonia, you've listened to their chest, then you do blood tests to help you validate that diagnosis. And the next thing, sorry, the next thing is, to track response to any intervention you make. So, for example, that person that has the pneumonia, you've treated them. Now you want to see that, they're improving biochemically. So you're not just improving physically, you want to see how they're improving bloods-wise. You do blood tests to track that they are improving. Another reason why you would want to do lab tests and is to prior to any like invasive procedures, you want to make sure, for example, if you're going to do a surgery or an invasive procedure, that their clotting is okay, and all their blood tests are fine for you to be able to do a procedure. So those are in general the main reasons why we do a blood test. And for those who have been working in the NHS, you know that unfortunately we do get a group of patients who are medically fit for discharge. That's what the MFFD means. You'll see that a lot when you first start. Medically fit for discharge patients. So these are patients, for example, elderly patients that have social, so they have social reasons why they can't leave the hospital. For example, they're requiring a package of care before they leave the hospital. So unfortunately, sometimes these patients can actually stay in hospital for a long time. I've had patients because they couldn't get a package of care, or they needed to be moved to a care home. It took a long time for them to be able to go into um to the care home or something. So you just, because they're in a hospital, you want to make sure that they're not getting a hospital acquired infection or something like that. I've just seen someone put something in the chat. Let me just see what that is. Okay, yeah, COW, cows are computers on wheels. Yes. um okay, so this is Theon. So you can see, one second. Okay, so to bleed or not to bleed. So these are just general principles so like I said, most of the requests you will be doing in terms of lab wise are mainly going to be blood tests. So you need to know why you're requiring a specific test, requesting a specific test, definitely you can't just be requesting tests and not know why. Sometimes your consultant will ask you during ward round to request some very specific tests, blood tests. Just, sometimes ask why, because if the blood test comes back, for example, and it's going to change some form of management, you need to say, okay, why are we requesting this blood test? What is it going? What if the values are a certain amount? What does that do to our management? That kind of thing. So you need to know why you're requesting a specific test, other than just requesting it and it comes back, you don't know what to do with it. Is the test going to change clinical management? Now, this is very, very important. Um, you know, just requesting tests. Tests without context is not important. You need to know why. Is it going to change your clinical management? For example, a guy falls off his bike and a 70-year-old man falls off his bike, he's injured himself, he's fractured his wrist. Does he really need a troponin test? Is it going to help, in this management at all? I don't think so. So you need to know if it's going to change your clinical management. And then start simple and build your way up. Do you don't obviously you've been filled with all this knowledge from medical school and things like that, and it's great, but you need to know why you need to start with simple tests first, because you could be missing a really simple diagnosis. I'll give you an example. We had a patient who was extremely, extremely short of breath. We're working him up to go to another hospital to have NIV. We've done all sorts of blood tests. We had a wonderful test. And then one of the registrars came and was like, actually, have we done a COVID test on this guy? And and we were literally teeing him up to go to hospital. And we're like, oh, actually, we haven't done a COVID test. We did the COVID test, and that just completely changed our management for that patient. So start with simple tests before you go up to bigger tests. And don't forget to put the request out for the phlebotomist. This is actually, if this is one of the big takeout points, from this talk. Don't forget to put out tests for the phlebotomist, because it just saves you time. One of the key things in becoming an F1 or F2 is knowing how to manage the ward. And your time management skills are really actually, I would say, more important than your clinical skills. So if you know in time when to put patient out for bloods the next day, or things like that. It just saves you time during the day instead of having to go and bleed the patient. I did that. I made that mistake yesterday, actually. I forgot to put out requests. And even the fact that these patients, okay, they weren't that hard to bleed, but it still took me time out of my day that I could have been spending doing more important things, and just and especially within the NHS where we're usually short of staff, you really need to have your time managed, and if you can use other members of the healthcare team to help you with that, that'd be really important. And then the next one is for most tests, you can actually do an add-on. So I didn't know this at the start. Anytime, they would say, oh, for example, you can see that from the test here, you can say this yellow bottle, the user needs, it's biochemistry lab. You can add on LFTs, you can add on amylase, you can add on calcium. So I would sometimes go and like re-bleed the patient. And so actually adding on these tests, is a lifesaver. And knowing what tests you can add on. Some of them are time dependent. So not every test you can add on. For example, I think a CRAG screen, you need a certain number of hours before you can add on a D-dimer or an INR or something like that. But it's still very, very important to be able to do these things. Sorry about this. Let me just turn this off. Sorry, I'm seeing someone. I'm confused about the phlebotomist request. Usually I see that FY doctors are the ones taking blood. So how is it? So in general, you can request phlebotomy. Usually, I mean, depending on the hospital, usually in most hospitals, there's a phlebotomy service in the morning. So you put out the request for the phlebotomist the day before for the phlebotomist to take the test. Now, obviously, if the phlebotomist is unable to take the test, then you take the test, then you draw the blood yourself. But it's better to put out the request for the phlebotomist to take, and if they're not able to take it, then you can go and do it yourself. But if you leave it and don't put any bloods out, you could have if the consultant wants a lot of blood tests the next day, you could end up doing like a mini phlebotomy ward round yourself, and that will just take you loads of time. So it's usually you can put out the request for the phlebotomist. So anyways, so sorry, okay, no problem. So yeah, so you can see these are all the different bottles for the different types of tests you request, and you can add on bloods. In group and save, you can't add on anything. You need to fill it out yourself and things like that. Okay, so next when we're moving swiftly on, and like I said, here context is always key. One of the things that people like to do is request troponins. Troponin, so as you know, is a test for when you're thinking someone has some sort of myocardial ischemia or things like that. And troponin tests can actually go up in a lot of patients. Patients with CKD on dialysis or patients who've had a stroke or things like that. So you need to know why you're requesting certain tests. For example, if a patient doesn't have a chest pain, they don't have any signs of anything cardiac sounding, why request a troponin? Because then what do you do with it? If the troponin comes back high, do you start treating them for ACS? So context is always key for the blood test that you're requesting. So we're moving swiftly on. So my slide isn't moving. So usually sometimes your registrar or your consultant might ask you to do routine bloods. And you're like, what does that routine bloods mean? So routine bloods can mean a lot of different things for different specialties. But in general, when we're talking about routine bloods, we mean your FBCs, your user needs, and your CRP. So but for example, I did orthopedics whilst I was in Leeds, and routine bloods for us was quite different. We couldn't, so when a patient had a fracture, a hip fracture, for example, they've had an operation, we do something called day 1 and day 3 post-op bloods. Those are our routine bloods. Now, with our routine bloods, we don't add on the CRP because, after surgery, CRP is usually raised. So in that context, FBCs and user needs are actually more important to us and then we add on other like kind of bone profile and BIP-D and things like that. But those are our routine bloods. So routine bloods in the gastro ward could include LFTs, for example. But in general medicine, when they talk about routine bloods, it's usually your FBCs, USNEs, and CRP. And obviously we know what the FBC constitutes of. It's, you know, your red blood cells, your white blood cells, and your platelets, and then, you know, eosinophils and other weird and wonderful things in between. So, you know, in, for example, my orthopedic example, you know, your FBC, if a patient's had a fracture, they've had a hip operation, you know, you're expecting some blood loss. So we can actually, the FBC, the HB, we monitor their HB on day one. You know, we can expect to see some blood, their HB would have dropped by day 3. That we expect to see, you know, it stabilized. Obviously, if it keeps dropping, then maybe we need to give them a transfusion. So those are important things, you know, in terms of our general FBC. And then obviously to track for acute and chronic anemia, and it can differentiate, you know, is there a macrocytic, microcytic, those kinds of things. So when your consultant's asking you questions, you can say, oh, I think they've got a, you know, anemia, and you know, it's microcytic or macrocytic, and actually with, you know, when you're clocking a patient, for example, we're in the NHS, they have electronic patient records. So those also connect with their GP file. So you can also see what their blood tests were like, you know, before they came into hospital. So you can then track, okay, is this an acute thing or a chronic thing? You know, in the terms of their anemia. And like when I'll go on to the next slide, you see that trend is more important than actual values themselves. So again, you know, your FBCs, your white cell counts, then, you know, if it's raised, and increase of a CRP, that's usually in response to an acute infection. But other things can also cause their white cells to be raised. So again, the patient, you're not treating the numbers per se, but you're treating the whole patient. You're treating the whole patient. So, and sometimes there is a CRP lag. So it's very important. Is the patient also on steroids? So it's very important to have the full context in view to be able to interpret the blood results. And then again, using the FBCs, using these on CRP, the white cell counts, if it's coming down, it can, you know, change you can prompt a switch from IV antibiotics to oral antibiotics, because, you know, they're improving. You're thinking about getting them home on discharge. So, and then platelets, sometimes, you know, in a lot of patients in the hospitals, they're on VTE prophylaxis. So that's venous thromboembolism prophylaxis. So, for example, if their platelets are starting to go low, there's a risk of spontaneous bleed. So sometimes that can prompt us to hold the enoxaparin, which is a low molecular weight heparin, to as a VTE prophylaxis. So, and then you have your USNEs and CRP. These are mainly for monitoring their kidney function, and, you know, disturbances in electrolytes. So you can correct the electrolyte hypokalemia, you know, depending on what the level is, we can correct it with oral supplements or IV supplements. So, and remember, in acute bleeds, there's usually an associated urea rise. So you get a HB drop, and you also get an associated urea rise as well with acute bleeds. And then always check for and then in renal function, creatinine is the most important thing. And again, like I said, you can go back to the GP records, for example, if they're coming in first, to see what their trend, what their baseline creatinine is. And that'll tell you, okay, is this a CKD or is this an AKI? Is this an AKI, meaning there's a huge rise in creatinine? And so we need to treat it a bit more aggressively, or is this a CKD, in which case, you know, the patient is fine. Basically, this is more of a chronic thing. So there will be a lot of words thrown at you, and sometimes the consultant will ask you, or the reg, you know, do a confusion screen. They're like, what's that? What's a confusion screen? So it's literally a set of like blood tests, lab investigations, and can also include you know, radiological investigations like X-rays, CT heads, to basically figure out why a patient is confused. You know, and you see a 80-year-old lady come in really confused off their baseline, what their normally is. So there's could be a number of different causes for that. So they'll ask you, you know, you can see all the things here. I took this from Geeky Medics, which is a really, really good website for when you want to find out you know, different blood tests and why they're requested and things like that. So you can read up on these, you know, FBCs using these. You can see a lot of different things can cause the patient to be confused, and we try to correct these things. So B12 and folate, you know, UTI, one thing that you really see in elderly patients is a lot of their confusion can be caused by a urinary tract infection. So, but just always make sure that, you know, even if they're not confused and you've done a urine dip, that doesn't necessarily mean that it's because of the UTI. I mean, a lot of elderly patients have symptomatic bacteriuria. So just be careful and make sure you get an actual urine culture before you start treating for a urine infection. In younger patients, you can accept a urine dipstick as a sign of confusion, as a sign of UTI. But in more elderly patients, more than 65, that's not usually sufficient. So yeah, you can see all these bloods. And then another website that's very good for, you know, why when you start requesting certain blood tests and things is a website called Mind the Bleep. So Mind the Bleep is a website for a lot of F1s, F2s use these. So again, if a patient's tachycardic and you're not sure what blood test to request, you know, one of the books I also used was this book, The Foundation Program. It was, you know, really, really good for me. So if your patient's tachycardic, you're not really sure what to request. You know, magnesium and bone profile is a good way to start. You know, you've done the ECG just to make sure you're correcting all electrolyte abnormalities. In the chronic anemias, you know, during the blood film, B12, folate, iron studies, just to know what type of anemia you're treating. And yeah, so you can see all of these bloods. There's a lot of panels of blood. They'll say things like, oh, do a liver screen, do this screen, and you don't always know what that is. But you can Google these websites, Mind the Bleep, Geeky Medics. All of these websites are very, very good. So we're gonna start off with a case study, and I would like, you know, you guys to interact with me if that's okay. Um, so so we have an 83-year-old lady. So she came in presenting complaints. Does anyone know what BIBA stands for? Or hazard a guess? You can either unmute or, you know, put a message on the chat. I want to, anyone just, you know, put in something that you think. What does BIBA mean? Or what you think it means? Anyone want to try? Okay, I'm not getting any responses. So BIBA, B-I-B-A, is brought in by ambulance. An 83-year-old lady was brought in by ambulance. So she had collapse at her local shop. So she mentioned she's been having epigastric pain and dark stools for the last few days. And she was due to see her GP in a few days regarding this, but obviously she came in a lot sooner because she collapsed in the local shop. Now, this is actually a real case that happened. I haven't put the past medical history because I don't want to give it away, but you go and you perform a quick examination. You go and clock the patient, you do a quick ATE examination. So the airways patent, she's talking in full sentences. Breathing, she's fine in that area. You do a cardiovascular examination. I'm just checking my time. You do a cardiovascular examination and you find she's tachycardic. You find that she's hypotensive and her capillary refill time is quite low as well. But she's alert. She's GCS is 15. BMs, blood sugars are fine. You've done that abdominal exam, and she has some epigastric pain, but her abdomen is soft. Now, actually, what test are we missing from this? Please, someone, just put something on the chat. What examination are we missing from above? What that you think? I might call on some people. Um, okay. Uh, Uche, Uche, what examination do you think is missing from above? Or are you not able to speak? Can anyone still hear me? Okay, let's see. Examination. No, we haven't got up to CBC yet. What examination is missing from the above? So you've got this patient that's coming, looks like she's been having she's had she's having dark stools basically. She's having epigastric pain. We're talking about examination before we go into to blood tests. What examination do you think we've missed out here? And this is actually really, really important. Yes, yes, PR exam. Thank you very much. So, yeah, so yeah, so PR exam. If you ever you're suspicious, if someone's been complaining of dark stools or anything like that, before one of the most important examinations you need to do on a patient in this case is to perform a PR exam just to confirm that, yeah, PR pyrexim exam, just to make sure that you confirm this. Um, a lot of, when you want to speak to other, people, they'll ask, okay, have you done a PR exam? So that's one of the things that I've actually been shouted at before for not doing when the patient mentioned a black stools. Um, okay, so blood tests we need to request because of time. So one of the tests I didn't mention is a VBG. It's a VBG or ABG. They're points of care tests that can actually tell us quickly what kind of what's going on. So in this patient, I mean, I'm sure you guys are probably thinking about what the diagnosis is, but we need to make sure, she's fallen, she's hypertensive, what can be causing she could be anemic. So one of the quick tests that we could do is just to confirm that is a VBG, because the lab test will take some time to come back. The FBCs, the USNEs, the LFTs, the clotting, they'll take some time to come back. So in the meantime, we get a VBG, and actually you can do all of these tests when you're putting the cannula in the patient. So as you've put the cannula in the patient, usually we'd go for a bigger, wider bore cannula. But once you've gotten, you can take the VBG from the sample, you can take the FBC using these CRP, LFTs, all of that stuff, and the cross match as well from this sample. So rather than bleeding the patient again and again, you can do all of this in one go. So yeah, that's and I'm sure you guys are thinking what the patient has. Okay, so this is the GBS, Glasgow Blatchford score, so bleeding score. So the patient actually had an upper GI bleed. They had an upper GI bleed, and this is one of the emergencies, and you can see that they fell faint. So they're actually symptomatic with it, or with this anemia. They fell faint, and they had a fall, they're hypertensive. So we need to kind of try and get blood tests in them, and we also need to try and stop the bleed. So we need to scope them. So this is another request that you would be making. So on this website called MD Calc, it's a really, really good website for calculating a lot of these medical scores and things like that. So it tells you, asks what the hemoglobin is, It asks what the nitric urea is. So again, if the urea is raised, it's a sign of a bleed. What the initial systolic blood pressure was. So if it's low, obviously that puts you at a higher risk of bleeding and subsequent death. What their heart rate is. So she was tachycardic. And was there any melena present? This is when you would go and perform the PR exam. And there's a few more things that you need to do, but obviously with a higher Glasgow Blatchford score, um, then that's increased bleeding. And then obviously we need to do the cross match. The cross match is there for letting you know the cross match is there for when we do need to transfuse them and you know get some bloods right into them straight away. So you need to do all of these before you need to definitely make sure you transfuse them before they go to the endoscopy. But you can see how all of these blood tests and things like that I've mentioned are helping you to, you know, form your diagnosis, and actually go and get a scope. So actually, this patient, in broader context, was she'd had a hip fracture. She had then she was started on VTE prophylaxis. So after hip fractures and things like that, we start them patients on VTE prophylaxis, and she had a bizarre kind of VT prophylaxis where they put her on really high doses of aspirin. Normally we don't do that in the UK, but she had this surgery done somewhere else, and they put on high doses of aspirin. She didn't have any GI protection, so she didn't have any pantoprazole, lansoprazole, or anything like that. So obviously she started noticing this bleeding and then became hypertensive and came into hospital. So we obviously had to quickly give her a high dose infusion of PPIs and things like that. So that's how all of these blood tests, you can see they all come into context with our clinical diagnosis, with our clinical examination to give us, you know, why we need the blood test. Okay, 5 minutes left. Sorry, guys, taking some time here. So then we're moving swiftly on to our sorry, to our radiology requests. So so we have our guiding principles again for our radiology requests. So so number one, so this is like a paper form of one of the radiology requests, but most of them you do online now, because a lot of the hospitals have electronic patient records. So all requests. So number one is you're responsible for all the requests you make. So that is in your name. It's actually a legal document what you're doing. So just be careful that you're not putting because someone will look at that and say this person made so request on that day. So you have to be very, very careful on that. Ensure your referrals are for the correct examination and for the correct patient. I can't stress this enough. Like if there's any takeaway again from this, make sure, because sometimes, you know, a person, you're concerned they fractured their right arm, but then you request because you're in rush because, you know, it's it can be a very, very busy ward round or something like that, and you're quickly trying to do the request, and then you requested like a left shoulder x-ray. So, and then actually that was normal. So then you think, actually, what did I just do? You know, I'm now gonna have to radiate this patient again. And that's actually a day ticks for you because you requested the wrong examination, although it was the right patient. You're now radiating them twice. Imagine if it was the wrong patient. So just be very, very careful. There's a mantra that I heard when when I was, you know, going on talks like this when I first started. They said slow is smooth and smooth is fast. So that means, you know, take your time. Make sure you're doing for the correct patient. Otherwise, by the time you have to cancel the exam or try to request a new one, you've actually wasted a lot more time trying to be quick and trying to do everything very, very quickly. So just make sure that you're doing that correctly. And then you're also responsible for ensuring the results of radiology referrals are acted on appropriately. So a lot of the time, some of the times the radiology requests can be happening out of hours. So if, for example, you're requesting a chest X-ray, you're concerned about a pneumothorax, and it's your time to go. You need to make sure that you've rung up the on-call to make sure that they chase, like, meaning they have to look at what the X-ray is showing and do something about it. Otherwise, if the pneumothorax happens, no one's looked at it, and then the next day you come in, someone's had a pneumothorax, and you didn't do anything all through the night. That's a day text again, and that hopefully the patient didn't die, or something happened. So just make sure that whatever request you do, you hand them over if they're not going to be seen by you on the same day. You're responsible for that request. That request is in your name. So just make sure. And you also have to provide sufficient clinical information so that the radiographer or the radiologist can decide whether that radiation exposure is justified. So radiation it does have, although albeit low risk of potentially causing cancer. I mean, so just make sure that you're providing enough information so that they can say, okay, is this test justified? Because the radiologists, they follow this principle as low as radiologically practicable. And then always remember women of childbearing age. So in any request that you're making, just think, oh, if she's between 18, I don't know, um, whatever the childbearing age is, I've lost my train of thought. Just make sure, could they be pregnant? Just always think it's always easier to just get a urine sample and ask for pregnancy than find out later on in line you've done a CT scan and the patient actually was pregnant. So just always make sure of that. So with this, we're gonna do I've written some requests for some patients, and I just want you to think, what am I thinking? So you have to guess the diagnosis. So I would like you guys to put in the chat what the diagnosis is, or what you think I'm thinking about, in order to, vet the sound. Think you're the radiologist or the radiographer here. What am I thinking about? So, and these cases are true, actually. I've tweaked some of them slightly, but they actually did happen. So we have a 56-year-old male. He presented to A&E with history of shortness of breath, fever, and productive cough, which was yellowish in colors for 3 days, 3 out of 7. So that means 3 days. 3 out of 52 means 3 weeks. Yeah, so these are little things. On examination, he had crackles on the right lung base, and there was dullness on percussion. White cell counts at 18, CRP is 150. So what am I thinking about? Exactly. Pneumonia. So you don't have to guess. You don't have to think. If I just put, oh, shortness of breath, then you're having to guess. So these are kind of how you should try to structure your request, so that you're not leaving the person to be guessing what you're trying to request. So that's good. So next one. So you can see here. So yeah, so I'll put query. So the question mark there, query right community acquired pneumonia. So you can see this is an example of a cat. Yeah, so you can see that the cracked ribs with no concern of pneumothorax are not an indication for chest X-ray. So if someone has rib pain, and you're thinking, oh, I think they need a chest X-ray just to confirm. So because think about it, is it going to change your clinical management? So you don't think they have a pneumothorax. What are you going to do? The main thing is analgesia to control their pain. So that is not an indication for a chest X-ray. So just remember, think about things that are indications and not indications. Another one, we have one more after this. So abdominal X-ray. So you have an 89-year-old lady. She had profuse vomiting. She's been vomiting 3 times during the nurse have told you during ward round she's vomited already 3 times this morning. She has abdominal pain. She has an umbilical hernia, which was irreducible. And then she has no bowel sounds on auscultation. She has also some right upper quadrant tenderness. Her blood tests show that she's hypokalemic, and this has not improved with oral replacement. So what am I thinking about? What do you guys think? Can someone put something in the chat? Okay, bowel obstruction. Yes, thank you very much. Bowel obstruction. So in this case, we quickly get, yeah, bowel obstruction. Anytime you see an abdominal X-ray and it looks like this, okay, your alarm bells should be ringing in your head. You know, this is a bowel obstruction. Either they need to, you quickly need to, you know, put a nasogastric tube down, drain them, and they need, if it's incarcerated or something like that, they need to go to theater straight away. So you need to be speaking to surgeons. So yes, that's it. And another one. So you can see how we're building the picture. I'm not leaving you to guess in this case. So in the next one is we have an 85-year-old lady on witness call in the bathroom on the ward. So you'd be asked for a lot of calls to come and see someone that's had a fall. You know, when you saw her, she was unable to mobilize, so she was laying on the floor. She has a previous history of a left hemiarthroplasty. On examination, there was external rotation and shortening of the right lower limb. So what are we thinking here? Okay, neck of femur. Thank you, Sarah. Very, very good. Thank you. Right neck of femur. Yeah, so we're thinking about, is this patient got, you know, it won't always be as obvious as this, but yeah, so yeah, we can see we've got the neck of femur fracture. So just always think for fracture we usually put the sign in the NHS. So I didn't know that initially. So right neck of femur fracture. So I'm giving the person a history of, you know, this person as likely osteoporosis because they've had a fracture before. This obviously isn't the X-ray of the person because otherwise you would have seen the left hemiarthroplasty done before. But again, I'm not leaving the person to guess. And that's the same principle you take for vetted scans. So the ones we talked about was non-vetted scans, meaning you can usually just put in the request and it will be done by the radiographer. They would vet it unless there's any issues with your request. Vetted scans, usually you need to talk to a radiologist. Like you need to talk to you know, to vet the scan. And CTPAs are frequently requested to rule out a PE. So the number of CTPAs that you will see, I'm sure I'm probably seen up to 100 requests done during my time working in the NHS. So these require a little bit more of a workup. So again, making sure that history is good. That's the basis for what you're putting in. But also, you need to do other things. So sometimes they'll, you know, do a D-dimer or a Wells score. And then sometimes they also, because, you know, with CT scans, it's, I think, 300 times the same amount of radiation for a patient. So we need to make sure that what we're doing is not caused by something else. So, so we check to see if they have a recent chest X-ray to rule out other causes of breathlessness, such as pneumonia or heart failure, something like that. And then, you know, we calculate the Wells score. What's important to know with the CT scan, the CTPA, is if the scan is unlikely to happen on the same day, you need to start the treatment dose of anticoagulant as per your local hospital policy. So just always make sure. So you have to be quite sure that you think this is a this is a PE, because if you can't get the scan done, for example, during the day and it happens out of hours, then you have to treat. And unfortunately, sometimes you have to weigh that against other risk factors for the patient. As for example, do they have, you know, a tumor, or other causes that could make it contraindicated. So you have to be very, very careful requesting a CTPA. So make sure you work that patient up before you then go for the CTPA. So this is again MD-Calc, which we use for calculating our Wells score. So you can see here, you know, is it likely? Do you really think it's CTPA? Have you done all the tests, the ECGs, have they been immobile? Is the history pointing you to a PE? Don't just do the test randomly. And yeah, so I think I'm rounding up now. So so anything CT, MRI, that kind of thing, you need to speak to a radiologist. And then there's some tests, depending on how big your hospital is, some consultants, some radiology consultants will say as a specialty review that patient before you get that scan. For example, an MRI spine. to rule out cauda equina. You've done all the workup for cauda equina, but time to say orthopedics seen that patient first. So again, all of these things, because they're expensive, these tests as well, you need to do a proper workup before you get them vetted. Or but the basis of it is making sure that whatever request you put in, you have good clinical information in there to make sure that the scan is done. And yeah, I think that's it. So thank you guys for listening.